Hey guys, Dr. Massey. Today we're going to talk about doing anesthesia for the pediatric patient. It's a little different than the adult patient. The anatomy is a little different and the bone is a little more porous, so in a lot of ways it's easier. You can get away with a lot of infiltration in places that you may not be able to with adults. So with that said, let's get started. I'm going to post a picture down below of the maximums that you're allowed to use for septo and lidocaine. For these demonstrations, I'm going to use, I personally like septocaine, but you can use either one. Just make sure to pay attention to the maximums. For the most part, there is very little reason to ever go above 2 carpules of either. For any patient, you can numb the entire mouth on a pediatric patient with 2 carpules. Most of us are going to work half mouth or a quadrant. I very rarely ever go above 1 carpule, but sometimes I do use a little bit over a carpule, especially if I'm doing a block and some infiltration on a half mouth. We're going to start with infiltration of the maxillary dentition. If you are doing maxillary teeth, you can get away with infiltration only. If you are doing a composite, then you can get away with just doing buccal infiltration. If you're doing a stainless steel crown or a extraction, you're going to want to make sure to get that palatal root really good and numb. A lot of times patients will complain of discomfort because you didn't get that palatal root all the way numb. So for the maxillary dentition, you're going to go straight buccal to the tooth you're working on. If you just barely prick the tissue just to get enough under it, when you start to apply the anesthesia, you'll get a little bubble under the tissue, and then just go really slow until you fill that bubble up with anesthesia. That's going to get that numb. For this tooth, same thing, you can just go buccal to it. Then you can go to the palatal. Again, make sure your assistant has done topical. Let's say that you're doing the first or second primary molar. I like to put a little bit just to the distal palatal and just to the mesial palatal. That's going to get that whole palatal and make sure that it gets down in that root. Same thing for the first molar, distal palatal, mesial palatal. If you're working on an anterior tooth, you can just go straight palatal to that tooth. On the maxillary teeth, once you do the infiltration anesthesia, give that tooth a good 5 or 10 minutes for that anesthesia to set in. You can go check your hygiene patients at that time and then come back, and then once you get ready for the treatment, you can test the tissue if you like with an Explorer or a periosteal elevator. Now we're going to talk about the lower dentition. If you're doing anything from the first primary molar forward, you can get away with just infiltration, whether you're doing an extraction or a crown or just a composite. You can get away with infiltration on the first primary molar forward. Same thing as above. You're just going to go at an angle and you're going to go slightly, just barely prick the tissue enough that you can deposit some anesthesia, deposit it really slowly. For that first primary molar, you're going to go just barely distal to that molar. You're going to start filling that tissue up. You'll see a bubble of anesthesia start to form, and then you can just easily back your way out of it. Or if you're trying to get a little bit into that second molar, you can just slide your syringe barely under the tissue, pushing that bubble ahead of you. It will push that bubble all the way to the back, numb that tissue, buckle to that. Then you're going to go inside and you're going to go just distal to the tooth you're working on. In this case, it would be the first primary molar. You're going to go just distal to that. Same thing, just barely prick the tissue. Very slowly put your anesthesia in. It doesn't take much on the lingual, and it'll numb that whole lingual all the way to the midline in the front. For the second primary molars, if you're doing something, either a very small composite or potentially even an MO composite, you can get away with infiltration, especially if you use septocaine, but you can also get away with it with lidocaine. So you're going to infiltrate the buccal and lingual just like you would, but then you're going to want to come back and you're going to put a little bit of anesthesia into the PDL of that tooth on the buccal. So if you'll apply a little bit right here on the buccal, you're going to go just distal, straight buccal, and just mesial. You're going to apply some of that. If you feel some pressure, it means that you're in the right spot. That's going to numb that tooth. If you're going to do something more invasive, if you're going to do either a pulpotomy or if you're going to do an extraction of the second primary molar, then you're going to want to do a block. And we're going to discuss that in just a minute. For blocks on pediatric dentition, we're going to want to be a lot more level with the occlusal plane than you would with an adult. If you're going to do permanent teeth on the lower or something such as an extraction on the primary second molar, I personally like to go ahead and block. That way we know that we have gotten it completely numb. You're going to want to let your block set in for a good 10 minutes to make sure you know you got it. But you're going to want to go in at an angle, basically come in between the canine and the first primary molar will give you a good angle. You're going to go into the ramus at right at the occlusal plane. As soon as you go in, just deposit a tiny amount, sit there for about 2 seconds, and then just depress your plunger very slowly as you move the needle forward. When you hit the bone, pull back just a millimeter, turn, go straight in right along the edge of the bone. Do not hub your needle. That's where we get needle break-offs. Do not hub your needle. Go until you've got several millimeters of the needle out, and then you're going to pull back on your plunger. Make sure that you're not in the vessel. Assuming that you get no pullback of blood, you're going to go ahead and deposit. I would typically deposit about 3/4 of a carpule, and then you're going to pull that back out. If you want to, you can hit the long buccal. You would have hit the lingual as you went through. Then we're going to let that sit for 10 or 15 minutes. You can come back. You can ask the patient if they're numb on their chin and their lip. If their chin is numb all the way out to the midline, chances are really good that they're numb all the way.